So actually we met about a year ago when we gave an IDSA talk. And I, after that, I thought, wow, I really want to know this woman. And because it's such a great talk. So fortunately, over the last year, I've actually gotten to know Preeti. And I wanted to kind of introduce you and then let her tell you her interesting story. So she is actually the Chief Health Officer at the University of Michigan. And she is an advisor to the president of the university on matters of health and well-being in the community. She also is a geriatric ID person and also is an associate editor of JAMA. She has, in addition to her MD, she also has a master's in journalism from Northwestern, which is a wonderful journalism school. And she also has a master's in clinical research design and statistical analysis. So I'm really excited about her being here today to talk with her and to tell us her story. And without any more ado, take it away.
Yeah, thank you, Kathy, and thanks for having me. And you know, it's been, I've admired your work for a long time, and it's been really a treat to speak alongside of you at ID Week, and then to work on the DSMB for the monoclonals, and then here we are. I'm happy to share a little bit about my path, and actually I prepared to sort of do a little background on writing and sort of, because I know people are at different points in their life, and writing's not easy for people. And I think frankly, it's gotten harder in the last couple of years, maybe at least for infectious disease doctors, especially anyone who's got caregiving responsibilities at home. It's really been really difficult to set that time aside. So I'll try to, give you some encouragement and maybe just some tips on clear writing. But my path has been kind of interesting, and Kathy, you kind of alluded to it. I actually looked this thing up. I'm going to share this link. You guys can read this up later, but this is kind of like my high school onward story of like, I started writing in high school primarily because I wasn't that good at math, and I had to take like 2 English classes instead of 2 math classes. And for me, journalism was just something that I really enjoyed and I liked. And I went to Michigan and I designed my own major in medical journalism and communication. Then, as you heard, I went to Northwestern, and I was very fortunate. This was more than 30 years ago, to go there and really like get a good foundation in journalism, and actually worked in between at a newspaper in Ohio at the Dayton Daily News. And I love being in medicine, but for me, I've always kind of had that. And infectious disease is sort of storytelling and taking a history, and there's a lot that goes hand in hand. And I know many of you are infectious disease physicians, some of you are researchers, but the way we think sort of applies to a lot of this stuff. And I got interested in editing, and I was an editor at Itchy, then I was the deputy editor at CID, and sort of always my dream to be an editor at JAMA. And this is my 10th year there, and I've had a chance to work with many wonderful investigators, and actually we published a lot of things on vaccines, not just in the last year, but really, for the last several years, including, some of the things that have come out of the vaccine clinical trials units. Mark Mulligan's work comes to mind with, the H7N9 vaccine and adjuvants. And, for me, it's been exciting because it's not a world that I live in, other than, I'm like, go get vaccinated. And I'm certainly, a big fan of it, but the science of it is complicated. But when it has such an amazing clinical piece, like it does at this moment, a lot of this work will be very, very relevant. So anyway, I'm trained in infectious disease. I'm trained in geriatrics. I'm still learning, I'm still like looking, and I'm kind of like, what is that next thing? And, knocking on doors, and maybe, sometimes people shutting the door on you, but just kind of thinking about ways to synergize, your interests. So I know that for a lot of folks, it's this very traditional path. And what I'm seeing from, being on the promotions committees and things like that at Michigan is that the world is changing in terms of team science, and And I think if you actually like to write and you enjoy writing and you can be a good reader and a good writer, you can add a lot to a team and you can be very productive. And frankly, if you hate to write, it's going to be a little bit of a slog, but then you can be productive by partnering with the right people too. So I'll talk a bit about that. Is that, Kathy, is that a kind of a good intro? And then
That's perfect. Thank you.
okay, good. And I'm going to get through this, and we can, if there's a way to do questions, I would love to take questions. So I'm going to share my screen if I may. Okay, and I am going to, this is kind of, I tried to put together what I thought would be useful for you. And, this is kind of based on Ego's comments, this idea of publishing your research, high impact journals. And, I will say that in infectious disease, our specialty journals are very high impact, CID, JID, and onward. And I'm really big about getting to the right journal, but I'm going to sort of tell this story a little bit from the JAMA perspective. I try to throw in a few things that I think are worth talking about, like data sharing and preprints, at least at a high level. And I'm happy to share this deck with you, including any of the articles that are mentioned. So let's see. So, one of the questions people ask me a lot is where should they send their work? And I think selecting the right journal is really important. And the publishing priorities are very different. And, basic science, immunogenicity study, except in the, during a pandemic, it's of course very, very relevant to the general world, but often those kind of papers are going to be in a more specialized title, more specialized journal. So be familiar with the scope and the type of articles published. So, if it's basic science work, go to a place that does basic science. Make sure you review the journals you're considering. Obviously there's some that we're all very familiar with, but these days, and Kathy and Ann and I, we remember going to the library to look at table of contents, to try to look at journals. I mean, our library actually doesn't even have books anymore. So this is pretty easy to do. And I didn't include a slide on this, but there's a site called Journal Author Name Estimator, Jane, in all caps, in Google will find and get you there. That's a nice way to kind of find journals that maybe you don't normally read. Someone asked me about a piece around ethics and vaccine, and and we use that to come up with some options. One of the questions too is like, is it worth shooting high and failing? I think it depends on how time sensitive your work is. I think it depends on if you're in a pandemic. I think it depends on if you're being promoted. But going to the right journal makes sense. I think more and more, journals, they're going to reject without review. There used to be this sense, and I'm talking about 20 years or more ago when I was a junior faculty and trainee. Well, I'm going to just send it there, even though I know they're not going to take it, because I just want to get some reviews. I have to say, I don't think that happens anymore. I think we're just at a point where journals are, and I'm going to show you some data from JAMA about how busy journals are that if it's not the right place, we're not going to review it. And I think that's the case so on down. And frankly, many of you are doing lots of peer reviews, and the burden of peer review is also a problem, like, asking people to do this. So again, it tends to be a subjective decision, and, journals pass on good papers that go to other journals. And I will say at JAMA, one of the things I point out to people, there's about 200 papers a year of research papers, and half of those are clinical trials. So if you have like a single center descriptive retrospective study, it's just not going to make it. And I know that hurts people because they feel like, boy, you made a decision very quickly. My take on it, and they often write and ask, and my take is that I don't want to hang on to your paper and slow things down anymore. So some of the things that are interest for a high impact general journal: novelty, clinical importance, validity, generalizability. So what does this mean? It means large multi-center clinical trials. People are really interested in the effect on clinical care or population health. This is where some things that are more like early, sort of basic science, immunogenicity, often they're not going to necessarily be in that space because the clinical effect isn't there. Now there are some examples, and from JAMA we had a chikungunya vaccine paper right at pretty much early in the pandemic. It was something that it took a while to publish. I think it was a phase 2, if I remember correctly. But it was this idea that it was kind of an interesting vaccine. It was different. Some of you may have worked on it, and so I think it does depend. It isn't that these things never make it, but but it's hard because you're competing against cardiology and oncology and all the other things. Large observational studies will also be in the high impact journals. What we talk about is a large effect on a rare disease and a small effect on a common disease. And, so you'll see things that are like really incremental for diabetes and hypertension. But, on some of the things that we deal with, they're still, fortunately, they're kind of rare. And so you have to really have a large effect. Public health emergency, of course, is going to be high priority. And we've seen that for the past year and a half. Less interest for a general journal is going to large, sort of high impact general journal, basic science without a clear clinical message. And again, I think that's just not, it's not the right journal. And Science and Nature and Cell, and there are other very, very high impact journals that might be better for that work. Single center randomized clinical trials tend to not also be quite as much interest, and it has to do with that generalizability and validity piece. Surveys, you won't see them that much. And if you do see them, they have to have at least 60% completion rate. Quality reports, again, they belong in a certain journal, but they're not going to, for example, we're talking about vaccines. And we're like, well, monoclonals. Kathy, we were talking about that. My brother is also an infectious disease doctor. It's a weird family thing. But he just had a paper in JAMA Network Open describing their program to get monoclonals to people using the local EMS folks. And my brother's actually an engineer by background. He's an industrial engineer. And so I think he thinks strategically. And part of why he got that paper published is that he was the first one to write it. And so I think that is actually a critical piece. Like, now other people are doing that, but they didn't take the time to write it. So it's like being the first sometimes can be helpful. 5-year rule, this is really important, and this happens sometimes. People get busy, life is complicated. Sometimes your results aren't awesome and you just don't feel like dealing with them. But if data are 5 years old, they're just not going to be looked at. And 5 years is a lifetime when it comes to vaccine work, and certainly for infectious disease. Confirmatory studies without new insights, small slices of information. Sometimes, especially in the health services world, people want to slice and dice information. And then, of course, qualitative research. Now, there are some interesting mixed methods, things that you will see occasionally, but things that are purely qualitative don't tend to be in the top tier general medical journals. Just some tips, don't feel bad about reaching out to, especially if you have something that really is a pivotal clinical trial. And I see Kathy nodding her head, and certainly her work has really, and Anne's work and others on this call, a lot of that work doesn't just come in cold. And again, if you are working in that world, certainly you're welcome to reach out to me at JAMA. But I think in some ways, there's this whole backstory to some of those really big papers where, it might be a discussion like, hey, we're wrapping up data, we're doing the analysis right now, and this is going to be ready to go. And we're interested in it, late breakers, things like that. So I will say with cover letters, make sure it's addressed to the correct individual. Like, make sure you change the letter, like from the previous one. If you're going to the next journal, like, editors are sensitive people. So indicate the importance of the paper. And, I think this is especially the case if it's like a second paper or it's a secondary analysis. Like, you have to really explain to somebody why it matters. And I often will guide people in that and say, in your cover letter, I want you to tell me why it's important so that I can share it with with the senior editors. You can also cite articles from the journal, and you can certainly suggest reviewers. They won't necessarily use them, but you could certainly suggest them. So why do things get rejected without review? I mentioned wrong journals, incorrect format, data are too old, limited novelty. Sometimes it's just poorly written, it's sloppy, wrong design, wrong analysis, which again has issues for validity. Sometimes sweeping conclusions. Sometimes it's just the editors having a bad day. That happens. And every once in a while, like the people will ask, they'll rebut the decision, and I have to say it's pretty rare that we'll overturn it. It's not impossible. It might be that sometimes people miss the importance, but I think more often than not, it's just a priority issue, and it's not that your paper isn't a good one. this is something that I actually, even my kids, I have young adult children, you know, like, what are the 2 or 3 most important points that you want me to walk away with? And this is whether you're giving a talk, whether you're writing a paper, but think about that and emphasize it in the results section of the abstract, in the conclusion, in the results section of the paper, in the tables, highlight it again. And I just think if you can, sometimes like I'll look at a paper that someone asked me to look at, and it's just kind of a mess, and there's just too many things there. And I say, what are the 2 or 3 things you want me to walk away with? And then just hit me over and over and over. And I think it's just a good tip for whatever you're writing. You know, the abstract, I'd say one of the things I've learned at JAMA over the last 10 years is how important the abstract is. 90% of us are only going to read the abstract, and it needs to have the key results and conclusions. It has to be accurate. Everything in the abstract has to be in the paper. The intro should be really brief. You don't need to put more than a sentence, maybe 2 at most, and really emphasize data. How much can you do with numbers? And, you know, putting as much info in there as you can. And again, I encourage all of you to look at the JAMA abstracts as an example, because we spend a lot of time perfecting those. Our format is different than New England Journal and Lancet, but I think our abstracts, when you read it, you actually understand a lot of what's happened. Our abstracts are pretty long also. Keeping uncommon abbreviations to a minimum. And again, in the vaccine world, certain abbreviations mean something else to other parts of medicine. And then I think having an outside reader to make sure they understand the importance is something that's helpful. I'm going to just like quickly go through this. And again, I'll be sharing all this with you, so don't feel like you have to write it down. But you know, in terms of putting a paper together, the intro is also something that is, something that should be very brief. And what we talk about at JAMA is 250 words and no more than 15 references. And it tends to be 2 paragraphs, maybe 3. And again, be a good reader to become a good writer. And I think that applies to medicine, but it also applies to writing more generally. And again, that's one of the things I've always told my kids is read, read, read. This is sort of one way to think about it. First paragraph, background, a few key references. Second paragraph, talk about why it's important. What's the problem? What are the unresolved issues? And then finally, whether it's a third paragraph or part of the second, the rationale for the current study. And it should really contain the study questions. The other way you could think about this is just what's the problem or issue? What is the importance of it? And what's your research question? And you know, if you put it simply like this, it's actually the intro kind of writes itself. And again, like I feel like if you've got the intro, well, we'll move on to methods. So methods tend to also probably be the easiest thing to write, in part because you've got other papers to use as models. You shouldn't plagiarize them, but you can use them as models. And this is really to describe how the study was performed. So subject, equipments, and again, in the vaccine world, you know, you're talking a lot about, you know, how you measured immunogenicity and how, you know, again, and I'm just thinking about geometric mean and like, you know, the different things that you write about. And again, looking at the papers that are really well done and reading like a beautifully written methods section can help inform how you do it. And I think, again, just having a certain order to this, subjects, equipment, IRB approval is big. Like that's something that we always want to know. Is it written, verbal, waived? Equipment, sources, what was done, how were the data collected? And then, you know, the data analysis is really important. And usually you have a statistician that's working with you on these, and that individual tends to be really so central to, you know, that's often one of the guarantors for all the data, you know, the person who had access to the data, but power calculations, statistical tests, you know, what you did with the data, how they were handled. So results section can only have results. And a lot of people, even very senior people who are really thoughtful and good people, they mess this up. They start adding opinion in here. So this should not be discussion or opinion. It really should be logical, and it should be very, very objective. And what I mean by that is no adverbs. So, you know, like don't like amazingly or surprisingly. I think people make this mistake because they put discussion into results. And if you read and you pay attention to this, you'll see this. And as you review papers, you'll see this. So results can only have results. And results only confirm or reject a hypothesis. You know, one study doesn't really prove anything. Each study adds to the overall understanding. And, you know, I think the big pitfalls people make are they don't provide the results they said they would, and they add interpretation. And the other big one, and a place like JAMA is really going to call you out on it, is that people try to put the secondary outcome up there instead of the primary. And again, and all of you are working in these areas, and as you are doing your studies, really get experience, like talk about, and again, I'm looking at Kathy, like when we were on the DSMB, sometimes we'd have they would present something and we're like, how is there not a statistical analysis plan? Like, you got to have a statistical analysis plan. You know, how do you not have, protocols? So this is where you're putting your money down on a primary outcome. You're registering the trial. And, you know, for those of you who are new to trials, learn this stuff, you know, tell your colleagues, you know, whoever's sort of leading the charge here, that you want to learn this. And I think the more you see it, the easier this becomes. So the discussion, I think the discussion is the hardest part to write. You know, let's be honest, like this is like kind of where the interesting piece is, though. This is a paradigm that I got from a really nice set of articles. And again, I'll share all these with you. They're a little bit dated, but they remain very, very evergreen. And, you know, again, I like this paradigm. And if you just put this together and then start putting stuff in, whoever's working with you can kind of help you carve, you know, really to develop a nice discussion. But describe the major findings, concise summary. Don't restate all the results, but just like a quick summary. Interpret your findings. This is where you get to say what this means. Compare your results to existing literature. Discuss all the relevant literature, including the literature that disagrees with what you found. Limitations, generalizability are important. A lot of people forget to put limitations, and even the best trial has some limitations. And then I think this is a place where you can propose additional research. The conclusion is sometimes freestanding and sometimes not. At JAMA, the conclusion is brief, and it matches almost exactly the conclusion from the abstract. I just wanted to share a little bit on JAMA, since you know, that's sort of my vantage point. Certainly, we'd welcome your best work. Impact factor is 56.3, pretty respectable. I don't know what's going to happen in the next couple of years with impact factors. I mean, they're the top general journals, they publish papers that have literally had tens of thousands of sites. Not so much JAMA, but certainly New England Journal and Lancet. Those first papers around COVID, even before it was called COVID, I mean, it's just going to throw these things off. So it's almost going to need a correction of some kind. But you know, we have a lot of visits to the site, 45 million. Downloads, 57 million. I mean, really, really big numbers, and a ton of media outreach. And again, we have online first, so articles, particularly late breakers, or things that are presented at a meeting, and so ID Week, ECMID, other meetings, the pediatric meetings. We love to publish things online first, and again, if we're not going to review it, a median time is about 2 days. So if you're not sure, and again, a lot of things I'm happy to talk about, sort of that cascading to other journals. And the other journal I want to mention is JAMA Network Open, and there is a feed published there. I think it's about 2,000, 2,500. Eli Parensevich is one of the infectious disease editors, as is Angel Desai, who had been a fellow at JAMA recently. They are publishing great ID work, and I think they're probably like the most direct competitors to something like CID. And again, a much broader audience. Some things just belong here. They probably have more of a general appeal. Now, there's things in CID that I love to read, but probably other people outside of infectious disease may not want to read. And I think the same is true for the vaccinology literature, which is even much more of a specialized audience. And the inaugural impact factor was 8.5. And again, 8.5 million visits, almost 16 million downloads. And I think this is one where, because a lot of really good work was published here during COVID, this is going to become a much more selective journal. So just a little bit about what happened at JAMA during COVID. These numbers are a little bit dated. They kind of were sort of January to September 2020 versus 2019. And I'm thankful to say that things have slowed down a little bit, but it remains really busy. So 18,000 submissions, which is a 134% increase. And at the network journals, almost 100% increase, about 90%. And about 60% of this was related to COVID. I think, as some of you know, the other portion is people who got sidelined and actually were productive at home, which is not everyone, certainly probably not the infectious disease folks, but some people got to write those things that were lingering. And 97 million views and downloads. This is just astronomical views and looks. And we still have this coronavirus site, and everything on there has remained free, as an important message around public health, like to make all this easily available to people. And, again, the alt metrics, just, sort of through the roof, millions of citations. Just in terms of some of the things we did, initially the COVID articles were really handled by the full-time editors. And then they kind of would reach out to like me and then Derek Angus from Critical Care, cardiology papers, people with EPID background, and really became this sort of really quick turnaround with the descriptive papers, because those didn't necessarily need to go out for formal peer review. We could do the peer review internally, or we could like tap someone who we knew was a good friend who would look at it. And Carlos Del Rio comes to mind. I know everyone knows Carlos well. And he and I ended up writing this series. Like I kind of joke, I'm like, this is like this next installment. I think we've written about 7 viewpoints together since the beginning. And it's kind of told the story of COVID as we moved ahead. And I was just thinking, I'm like, gosh, we got to write about flu and COVID right now, because we're starting to see those numbers come up. So again, people like that ended up helping us with peer review by quickly looking at things. And then as things became more clinical trials and vaccine studies, that's when we did external peer review, but we had to really ask people to do the things quickly. And that's always, there's a letter missing here, but basically I just want to let folks know that when it was something that influenced clinical practice, the external review got conducted, but it got conducted in a very rapid fashion. We asked people to do things in a couple of days, which is really tough to ask, but they did it. This is just another depiction of what's happened with manuscripts, just huge increase. And some of that increase has been sustained. Some of it is dropped off, thankfully, but in general, we're just way above our 2019 numbers. And I joke that this kind of is like the wave of COVID. It's just like the numbers have gone up with cases. And again, one more depiction of what's happened. Just acceptance rates, people often ask about this. And 2020 acceptance rates, this is for infectious disease manuscripts, is about 5.8%. And again, a lot of that was because it was viewpoints. So some of that was a little higher, but for research papers, about 2.3%. 3,700 papers that fell under infectious disease at JAMA, and 92 were accepted. So 92 papers is a lot, and 3,700 is like a huge number submitted. And then this was early in 2021. 950 submitted, 36 accepted. I'm going to shift gears for a moment, and I just want to talk a little bit about. I don't want to spend a lot of time on this, but I want to talk a little bit about preprints. And JAMA kind of had to make changes in their policies. I have to say, in 2018, if you wanted to do a preprint, you were chided, no preprints, and then it was kind of case by case, and it became completely acceptable by 2020. And in fact, some authors, I think it's like now the discussion is really about trying to improve the preprint process. And this year's ID Week, I actually did this pro-con around preprints with John Lynch from University of Washington. And it was kind of fun because it's, this idea that, okay, this is there, there's different servers, and it's here to stay. So how do we make it better? And I'm going to quickly go through this because I want to make sure we have enough time to take questions. But preprint servers, just for people's background, it's the idea of posting a manuscript prior to peer review. And my sense is the vaccine papers preprints were really, really popular. And in fact, press releases were popular. I'd much rather have a preprint than a press release, but that's a separate story. You know, we've been doing science by press release a little bit when it comes to these life-saving, novel, innovative, sort of world-changing vaccines and those studies, and it's been really exciting. But it's also been a little bit like, where's the science? bioRxiv, you know, started in 2013. Again, these are some papers that I think are, if you're interested in this, like worth reading. Now there's like about 60 preprint servers, and they vary in quality. Lancet has had their own preprint server for a while, and you know, the question is, do they ever do harm? And like, you know, ivermectin, you know, I'll just say the one word to folks on this, and like, you know, there's probably some harm there from a preprint related to ivermectin. And you know, these preprints end up living there, and they can be cited. And I think that the next iteration is really going to be like, what should happen to a preprint that never makes it to publication? And like, you know, should it be replaced by the publication? And so I think I want people to just be aware that this is something that's very dynamic. And I think you'll see this continue to be part of the discussion. And again, this is pre-pandemic. You can see the number of preprints placed in bioRxiv, which is really like one of the gold standard preprint servers. And it's just been taking off. I'd love to see the 2020 data. I don't have that. medRxiv is different, and it's kind of, you know, related. And I think they tried to do as good of a job as possible. It was launched in 2019, just in time to become very, very important during the pandemic. It's been focused on health sciences. They actually preview the manuscripts, and they do decline some. And I think, you know, the idea was really to share and comment and receive feedback. I actually didn't mention that, you know, way back, and some of you may know this, that preprints really began in sciences like physics and astronomy, where the idea was trying to get input on things, but also to claim, you know, that, hey, this is original work, to claim provenance of the work. There's some concern that people are going to scoop you or take your work and things like that. And some people don't want to use preprint servers, but I think, again, you will end up seeing these. You'll probably cite some of them in pieces that you write. This is something that the former editor of JAMA, Howard Bachner, wrote about this idea of the rush to publication. And, you know, it's like, what is, you know, and I think his point was always like, gosh, it takes years for a clinical breakthrough to reach patients. So why are people fussing about a few days? And it takes a long time to plan and execute studies, so really getting it right. One thing that we've done at JAMA is late breaker sessions at meetings, like getting those papers ahead of time, really putting them through the review process so that as they're presented, like it's this magic moment when the last slide is like, oh, and by the way, here's the paper. I mean, that's always like a thrill to me as an editor, but also a real thrill for the investigators. And again, I think journals are being asked to review papers very, very quickly. And this has especially been the case during COVID. And not everything is as time sensitive, but I will say vaccine work is probably, you know, like pediatric data right now, for example, you know, that's extremely time sensitive. Data sharing, I don't have that much to say about this, but again, I thought it was probably very relevant to this group. This is something that is emerging. I think funders are asking for this, and just something to be aware of. And this is an editorial that came from a number of the really the top editors, the ICJME board, you know, really the editors from around the world, in the top general journals. You know, this idea of requiring data sharing. And here's an example of a data sharing statement that's now produced for clinical trials in JAMA. And I think, again, more just awareness. I don't really know the right answer, like whether you should be sharing your data or not. But I think this is something that there'll be more and more pressure for transparency. And I think it's complicated. Like, so if you share your data and someone finds something different, what does that end up meaning? That's a good discussion for another day, maybe over a couple drinks, actually, because that is like a very complicated issue, one of the many. I just wanted to end by showing you a few papers recently. These are kind of in the last couple years, papers that I handled, just to give you a sense of some of the good infectious disease work that's been in JAMA. This trial was, sorry about that, that's my puppy barking. I think my daughter must be coming into the house. So anyway, this is the effect of amoxicillin. Sully, hey. This is effect of amoxicillin dose and treatment duration on the need for antibiotics and retreatment. And this actually just came out, I think it was last Tuesday. This is this paper actually required a lot of work to get it into shape, but I thought it was very, very important. This idea of shorter duration, lower dose, something very common. Frankly, probably most of these kids have viral infection, and which is probably part of the reason that there wasn't a difference. But this is the kind of thing that we would publish because it affects clinical practice. And then, here's another one that this is 7 versus 14 days of antibiotic therapy. Afebrile men with urinary tract infection. This was done at the VA in Minneapolis and in Houston. And again, really important study because it helps move us to shorter therapy. And I think just my own interest in antibiotics and stewardship, some of these papers I end up really trying to get them to come to us. These are a couple more that, this was a nice one that got presented at ECMID by Angela Huntner a couple years ago. And again, C-reactive protein, which is not something we use that much in this country, to guide therapy, 7-day versus 14. And, this idea of like, what happens with uncomplicated gram-negative bacteremia. And for those of you who are clinical infectious disease doctors, this has really shifted over time in adults where we're really using 7 days in most people now. And I think, again, it's been trials like this that have informed that. And the idea of multiple trials informing that. And I did want to show an example of something that's not a clinical trial. This was like an example of a really important cohort piece. And this got published earlier this year, and it's from 2017. So, we're talking 4 years on the length of the data. The authors kind of got a little bit of a pass because they're mostly CDC folks, and they've been busy dealing with the pandemic. So it's been hard to get this work done. But this was a point prevalence study on antibiotic use in a cohort of US nursing homes. So again, really important work because it is one of the places where stewardship is not as robust. So it really helps inform folks. But again, I think as an adult infectious disease doctor who is a geriatrician, this was something that really spoke to me and something that I really was able to help advocate for. So I'm gonna end there with greetings from Ann Arbor, a little go blue. Sorry, Kathy. Sorry, anyone else. I hope no one's from Ohio State. I don't know. Laura may maybe is Buckeye fan, but
border town. I'm from the border town, so we go half and half in my house.
Okay, well that's good. But anyway, that's I'll actually stop sharing, and like I said, I'm happy to share any of these slides with folks. I'll make a PDF of them.
That was wonderful. Questions. Now you have someone that you can ask the really hard questions about your paper. So please ask.
Yeah, you can ask anything. I'll do my best to answer pretty candidly. So
Preeti, this is Anthea. That was wonderful. Thank you so much. And I'm glad you brought up Jane, because I have attempted to use Jane in the past. And what I find is when I kind of put in the major topics, it gives me a list of several like journals that I have no clue about. And then I go and look at them. So once you have kind of put what you need to put into the search engine, how do you determine which of those 5 or 10 that they give you that you would anticipate submitting to?
Yeah, it's a good idea. And I think, frankly, the use of Jane for me is like when I have a paper that hasn't like made it in my usual journals, and
okay.
Right, like because for my world, it's like it's a lot of the work I've been publishing lately has been related to our National Pool on Healthy Aging. So it's like JAM and maybe JAMA Ophthalmology or JAMA Neurology. Like JAMA never wants them. JAMA Internal Medicine doesn't want them. But sometimes we get stuck. Like we had one on caregiving, where we're just like, gosh, what? And so, it was more like, oh, this sounds like it's a reasonable journal. And then, you kind of look at what else they publish. And, I don't drive things based on it. Some people are really, I didn't talk about impact factor other than sharing JAMAs.
Yeah.
There's a sense like, oh, well, if it's not this impact factor, I just think that that's, you know, some of the best ID journals don't have a high impact factor. And I think that's probably very much the case in vaccinology, because the stuff isn't cited that much, right, outside of that world. So use it to find like a home so that you can just move on, but also to explore titles that maybe you haven't thought about. You know, like hospice palliative care is another area that some of my work touches on, and it's not an area that I necessarily read about all the time. So even just hearing about journals, public health journals too, there's like a million of them. But I have maybe on one occasion where I had something that was like just really had a lot of issues. You know, it was well written, poor response rate. It was, you know, about antibiotics and LVADs. No, but we went to like, I'm like, what is the worst thoracic surgery journal? Like in terms of low impact factor, low bar, and we ended up publishing it there. So,
Right.
So, you know, you got to do what you got to do, not because
Yeah.
your science isn't good, but it's not always a home run.
Thank you. Thank you.
So,
Other questions? I think you're a little tougher than I am about, you know, usually if people write me back after we've said we wouldn't review something and they have a, you know, they sound compelling and not whiny, I'll often say yes, but again, it means more work. And I guess the other thing that we're starting to have some difficulty getting reviewers. People are tired. You know?
Yep.
I mean, I'm just keeping, you know, I'm asking the same people to review, you know, vaccine efficacy papers, and I'm pulling out all my chits and it's just not working. And, you know, last week Lancet sent a paper and they said they'd pay me to review it. So what are your thoughts about getting paid and all that stuff?
Yeah, you know, Kathy, that's a really interesting point. And I think that reviewer fatigue is real. And right now, you saw the numbers. I mean, these are COVID papers, and you know, they're not even like, I mean, to ask someone right now to do more, like it's just beyond. And you know, we have someone. So one of my colleagues actually, who knows a ton about virology, and he's a clinician also, but understands evolution, viral evolution, and we had all these papers on variants. And we're like, I don't even know. Like, I'm like, I don't know if this is good or not. And so what we did is we sort of contracted him to just say, give us a thumbs up, thumbs down, and like just write 2 paragraphs, because these are only going to be research letters anyway. They're not going to be papers, but help us figure out which ones we should go with. And so I think that was a very exceptional situation. I don't know, you know, like I think reviewing it's really good. In some cases, and if there's an editorial and you do a good review, you'll probably be the person who gets asked to write it, hopefully, maybe. But if things are not in my area of interest, I just say no these days. I recognize that peer review is really important, but I don't have a good sense. And I think, again, the journals that are well resourced are going to end up being okay. And there's just so many journals. We didn't talk about that. Like, there are a lot of journals. Like, you can kind of pay to have your work published somewhere, you know. But that's not the kind of work that any of you, I mean, I just don't think we're talking about that kind of work. I think we're talking about, I mean, how many vaccinology and infectious disease and public health journals that there are out there, and there are a number, and trying to just match it to the right one.
I have a question and a comment first. I'm Helen Stankiewicz from the University of Washington, and I just want to share my experience. We emailed you a couple of months ago to inquire about a potential paper submission, and I was like, when my mentor say, okay, send an email to one of the editors, I kind of like panicked, but you email us back in a very nice email with great suggestions. And I was like, oh my gosh, you know, it was just a very friendly email back from the editor, so or from the team. So I was very pleased to see that. I just want to mention that. And my question is related to and your thoughts, or what is the vision or plan from these big journals regarding inclusivity or diversity in clinical trials? I know that for JAMA, there is they required to report the race or self-reported race, etc. But you know, what is next? What is there any plan for a next, or like an action plan for how to encourage that in those big you know, vaccine trials or big trials are being published out there? Yeah.
Thank you, Helen. And I really appreciate that comment. I'm glad, you know, and again, I feel like it doesn't take very long to just be kind in a response. And even if it's like, you know what, this is great work, it's super interesting, but it's not a great fit and I don't want to waste your time. And, you know, and I think you can say that in a nice way, but I think you should also reach out because, you know, you never know. It's like, you know, this is kind of interesting. Let's get it reviewed. And the piece on the clinical trials, you know, JAMA has for forever, like as long as I've been there, always asked for how race was determined, you know, ethnicity, self-report, and why it was done. And they actually just had a piece recently about all the updating of even the terminology and like the decision to capitalize white and Black. And, you know, it's pretty interesting stuff. And it applies really, it's the AMA style ends up being, oh, good, thank you. And they were very thoughtful in putting that piece together. You know, the piece about, so I don't think the journals are going to drive the piece around diversifying trials as much. Although, you know, if you have a trial where it's not diverse, like that's going to be a weakness and a generalizability. And on the flip side, I think that this is something that all of you, you know, especially with the network, to really like try and make sure that we're representative in our trials, and especially in the United States, where it's just truly like, you know, a real diaspora here, right? Like, and we saw this with COVID, but you know, from the JAMA standpoint, like I think it's more like it would just be kind of weird, like to see something less diverse. Now, I will say some of these trials are done in Europe, where I think the population is sometimes less diverse, not always, but you know, like they go to Romania for some reason, right? I don't know. Is that my impression anyway? That people do a lot of studies in Romania and you know, the Baltic nations, and to me, I just don't think of that as quite as diverse.
So I had a couple questions. Thank you. That was a fantastic talk. Really fantastic talk, actually.
Thank you.
I appreciate it. And so 2 questions. The first one is, so I'm co-writing a paper with 3 other colleagues in my division and tons of others in the middle, but it's like the 4 of us were like really all the senior authors, you know? And so we have tried to put each other in the front and the back and all the stars and all the asterisks, and we're all, you know, corresponding authors, but people are saying, no, you can only pick one. You know, this is really limiting team science. The authorship line is severely limiting team science. And I was just thinking about how, like, you guys need to start doing authorship in columns or something. Like, I don't know, but is there going to be a move towards that? Because right now it's like we're judged, right? I'm judged by how many first and last author, how many corresponding authors. And I feel like and there's just not enough spaces for all of us. And yet we all were very important for different reasons.
Yeah, you know, I think that, you know, Erin, it's an interesting point. And, you know, I've sat on, I chaired our promotions committee for the Department of Medicine. And I think this is something that is really, you know, it's tough because, and I think about the big project I did as an ID fellow, which is, you know, a long time ago now, is I ended up second author on that because someone had to be first. And like, you know, we didn't have a little asterisk, you know, we didn't do it. And, you know, it's fine. Like the world has moved on, but it was hard, right? Like that second paper never got done. And so I never got that second paper. Would it have changed my life? Probably not. But you know, it's something that I've just thought about now in listening to you. And I think it'll be interesting to look at science, like more like basic science, because they have like 1 million authors, right? Physics papers, like there's like hundreds and hundreds of authors. Like we actually, you know, if someone says they're an author, we don't question it. But sometimes I'll say like, gosh, did you really have this many authors? we do make people certify what they did. And I think your point is well taken. Like, I think that there's a couple things, you know, like you can put asterisks in that, but, you know, at some point you really can't have, you know, I think first, last, maybe second, and corresponding. And I think the way you give people, you know, in the end, like someone's got to be first and someone can be last, but I do think corresponding matters. And when you do present it to, you know, and I think if the data are presented, you could always have somebody present it at a meeting, maybe at multiple meetings. But in the end, it's really difficult to have equity, right? And I think this is something for all of you who are more senior. You know, with my research team, like, I'm just like, you know what, you be senior. I don't need to be senior on this. Like, I've started really doing that aggressively because it doesn't make a difference in my life. And so I think some of the places where it doesn't make a difference, and those on this call that are in the position to make that happen is like, you know, take yourself out of that conversation, even if you are really probably the person who did the work. Not in a way that's scientifically dishonest, but, you know, it's time for someone else to do that. And I think you got to talk about authorship before you write the paper too. And it's an awkward conversation. And I think people who do the work need to be authors, and people who don't do the work should not be authors. And I think that is just as important. Like all those people in the middle, how many of them really, like, they walked through the room while you were, you know, writing the paper or something? And I think we have to be tough on that too. I don't know if I made any sense. I don't have an answer, but you know, it's interesting. It's something I'll keep my eye on.
Yeah, I was just curious if journals were thinking of new innovative ways to.
I don't think so. I don't think it's journals that are the limitation there.
Okay.
I think it's the teams. Then,
something else, we're running into larger and larger teams. Like we've got 10 site, 15 site trials where,
yes.
I mean, maybe we can fit on 1 or 2 people from each site, but each person that headed up each site was essential to get their, you know, 10% of patients in. And so we're running into these massively long author lists.
Yeah.
And one of the things I've seen is you do, like, you're listed in PubMed as an author, but not on the byline.
Yeah,
and that's starting to become useful, I guess. But
yeah, and in fact, that
problem.
CAPIT trial, the one that was just published last week, the PEDS Amoxicillin, that one was a mess, as I recall, in terms of the authorship. And there were like issues where all of a sudden, like, a couple authors showed up in the byline who weren't there, and I'm like, whoa, wait, what's going on, you know? And because we check all that. And like, so I think that one, you can see how it was done, where there were a couple groups, and again, the funding agencies, and it's a long author list, but some of it is kind of, you know, there's like these tiers of authors almost. But I think when it's like really, you know, you're running the show, like, you should fight to be, you know, first or last, whatever's appropriate. And I think, you know, those of you in the position to fight for more junior people to fight for that too, because I think this whole honorific stuff is just got to go. It's dated, and it goes against equity and inclusion, for that matter.
Yeah, thanks. So second question, I'll make this one really quick, but there was this paper that published in my area, and then they published a follow-up paper which negated their first paper. So they had this one seminal finding in the first paper, a second paper, and they put it in the supplemental, and it was like, oh yeah, we didn't find that relation at all anymore. I'm not even kidding. It was published in Science. My head was like, you know, the head exploding emoji.
Yeah.
So I wrote, Science now does e-letters. So I wrote an e-letter on it, and it was published and stuff. And no one ever responded. Nothing ever is going to happen. So like, what do you do about these papers where people write a letter to the editor and they're like, by the way, this paper was published in Science with seminal finding, and their follow-up paper, they didn't see this relationship at all anymore. What? I mean, and
yes.
I'm not saying that won't ever happen to me. So I'm not saying like they're horrible people. They at least published, I guess, the correct version the second time. But like at the same time, like the Science paper is never going to move in its preeminence. Do you get what I mean? It's like I think it's a problem.
And you know, and again, without knowing the details, it's a little bit hard to conceptualize. But I think this is where we got to get back to in-person meetings and have these discussions and be like, hey, did you see this? Like, this is really important, because I bet there's a handful of other people that really focus on whatever this topic is. And like, I think this is where social media and like, sort of different networks and stuff also are important, so that people even understand that this happened. Because that's really a pretty unusual situation.
So this never happens at the journal then, right? Like these retraction processes, or like,
Well, I mean,
I'm not saying they would
retraction
retract
is
it, but-
different. Retraction's different, right? Than like you did the study and then got a different result. I mean, that happens sometimes, right? I mean, like there's certain ones, right? Like not ivermectin and, hydrochloroquine, but like, I don't know, steroids in the ICU. There's differing data on that. And I think this is where meta-analysis, usually not. Yeah. Maybe you got to do a third study.
Well, thank you so much. I think
Welcome.
that it was an excellent presentation. We really would like to share the slides. In fact,
Yeah,
I think
I'll do that.
I think that the keys that you have about putting the paper together is really important. I think it also, you clearly showed that editors and associate editors are nice people and reasonable, so that we'll all make it. So we're not going to, just like Helen said, we can write them and they'll be nice to us.
Yeah, no, we should all be nice to each other. Seriously, we gotta like start there. Good.
Absolutely.
Well, thanks for having me. This was great. And thanks again, like
So much.
reach out. Like we would love to see your big trials. So
Absolutely.
Good.
Thank you so
Good.
much. Thank you, everybody.
Take
Have a
care.
good day.
Yep, bye.
Ciao now. Bye-bye.
Bye.